I'm Andrea Roane, and welcome to For Our Sisters, a conversation on breast cancer. Before we start the discussion, I'd like to tell you about the woman to whom this program is dedicated. Dr. Lori Wilson was a professor of surgery and chief of surgical oncology at Howard University School of Medicine. She was a highly regarded cancer surgeon known for groundbreaking and innovative research. Her personal battle with breast cancer gave her a unique perspective and insight. Dr. Wilson was a tremendous resource and advocate for women at Howard and the Washington community at large. Working with the Howard University Cancer Center, Dr. Wilson participated in hundreds of community events. She spoke passionately to women about the risk of breast cancer and the importance of cancer screenings. And because of her diligence and compassion, countless women received access to preventative care and took measures to ensure their health and well-being. Sadly, Dr. Wilson succumbed to cancer last year, but as you'll see in our program today, her legacy continues. We'll be covering a lot of important topics on our show, from family history to patient advocacy, so you might want to take some notes. We'll discuss the latest breast cancer research and present stories of hope and healing. Some cancers run in families, and the risk of developing certain types of breast cancer are higher if there are close relatives with the condition. For those families, genetic testing may be crucial to early detection and prevention. Edith P. Wright died of breast cancer in 1982. She was 39 years old. Her daughters, Miriam Wright McKinney and Wendy Johnson, were 10 and 21 years old, respectively. They're both here today. Along with Miriam's daughter and Edith's granddaughter, Jasmine Smith. We'll hear their story and learn about the organization they started in their mother's honor, the Edith P. Wright Breast Cancer Foundation. We'll also discuss the genetic implications when a family member is diagnosed with cancer and the value of genetic testing. Grace Ann Fasaye is Senior Genetic Counselor at the National Institutes of Health, where she provides support for patients enrolled in genetic research programs. Ladies, thank you all so much for being here with us. Let's start with Edith Wright's wonderful family. This is a woman who was 39 years old when she died of breast cancer. But Miriam, let's start with you. How old was your mom when she was diagnosed with breast cancer?
She was 34 years young. So that was in a time, late 70s, when there was much left to discover.
And lots to discover, but what did you know as a 10-year-old when your mother died, let alone 5 years old when she was diagnosed? Did you know what was happening to your mom?
I did not know. I had zero clue. It wasn't something that was discussed. I knew that she was here one year for Christmas in 81, and I got Barbies. And then in 82, I got a coat. So that was what's happening here. And a reality, a harsh reality really set in.
Wendy, you were the big sister. You were a teenager, but did you know any more than Miriam did about what was happening to your mom and why?
I knew my mom was sick, but it was during the time when families didn't talk about things that were negative or bad. They didn't want their children to worry. So at 16, I was concerned with trying to keep up with my friends. My mom is like, you need to come in here and learn how to cook, or I need you to take Miriam to Girl Scouts, or I have a PTA meeting, I'm just not feeling like going. And I'm thinking, take her on your dates, all those, all those things as a mom. But hindsight, I realized she was preparing me, and without even saying a word.
Was there anyone else in your family, close relatives, who was diagnosed with breast cancer or any other cancers that you can remember?
Cousin that have had breast cancer. So, growing up, and even as an adult, you're writing down your family history, and I'm thinking about my mom's side of the family, because she had breast cancer. And then one of our family reunions, it hit me like, I know this. Like, why am we not putting this on our medical records?
Right.
So we started
your dad's
talking.
side of the family as well as
Yes.
you get the DNA, the genes from both sides of the family,
correct.
so you need to talk about it.
Yes.
Did you practice breast self-exams, mammograms, clinical exams? When did you start checking your own breast health?
Right after my mom passed away, I started checking. Again, I was the oldest. We had another sister, Rhonda. who succumbed to lung cancer about 7 years ago, but we all started ours early in our 20s.
And Jasmine, you're the young granddaughter. You didn't even know your grandmother, but you know that this is something now part of your family history. When did you start practicing breast health, early exams, mammograms, clinical exams?
Yes, I'm 25 years old, and that's how long this foundation has been running. And I have this family that always encourages you to know your body and to, if you feel something, say something. So as soon as my breast started to develop, high school is when I first did my first self-breast exam. This year, I turned 25, as I said. I attempted to get a mammogram, ended up getting an ultrasound instead, but, we're always advocating for learning about ourselves and to early diagnosis.
So your grandmother's legacy is this foundation. Wendy, tell us about the foundation. What's the mission, the goals?
Our mission is to provide support services to families facing breast cancer. Our mom was 39, so we try to think how can we let her legacy live on, and that is through household cleaning, transportation services. We have a program for children who have lost a loved one to breast cancer. We have health fairs, so it's all things within a day-to-day of any family. So that's how we want her legacy is living on through us.
And Miriam, you're also involved with the Rosemary P. Williams Mammo Day in Howard?
Absolutely. We've been in partnership with the Cancer Center for well over 10 years now, and we provide breakfasts and baskets. That's one of our programs. And it's to encourage persons who are coming and getting their mammograms. It can be a little challenging or scary to come and find out stuff. So we provide food, baskets, activities, hugs, smiles, jokes, music, whatever it takes so that they feel more comfortable.
The things that come to the heart and soul of every person and comforts them. Now, we're talking about genetics and family history. When did you consider genetic counseling? You hadn't done it before. You're considering it now. Why now? Why not earlier?
I'll start off with that. Being 62, I'm like, I don't have grandchildren yet. I hope my sons are listening. No, I'm only kidding. But
No, she's not.
But what will happen when I'm not here? I know we have our foundation, but do we have our history? So in the beginning, I'll say 20 years ago, it was when healthcare was going through the change, pre-existing conditions. I didn't want my name tagged to anything, if something did happen to me that I wouldn't be able to get help. And so we started working with Howard and University Cancer Center, and they tried to encourage us to get our genetic testing. And even Dr. Lori Wilson. So she is a big advocate for our organization. But now, I think it's time. We need to do it. Jasmine is 25, as she said. We don't have grandchildren in our family right now, but we need to start it right now so Jasmine can carry it on, as being the youngest one in the family.
All right. You want to start it, but Grace Ann, what makes these the women prime candidates for genetic testing?
Right, so that's a great question. So what we know when it comes to genetic testing, typically it's not offered to everyone just yet. We look for certain sort of red flags, or should I say pink flags, when it comes to breast cancer that make us, a little bit suspicious that there could be a genetic factor involved. And one of the key things is being diagnosed as a young woman in the 30s or 40s with breast cancer. And so I know that Wendy and Miriam's mom was diagnosed at 34. So that alone is a factor, sort of a risk factor for carrying a genetic variant, or mutation is another way we sometimes refer to it. Cancer is typically a disease of aging. People get it as they get older. But when someone gets it young, we wonder if they have some biological genetic reason why they got it young. So really that's the main reason why it would be recommended.
What's involved in genetic testing? What does that actually mean?
Right. So genetic testing involves reading through a chemical sequence of a gene, the DNA of that particular gene, to see if everything's in order and nothing's misspelled. That's what happens in the lab, but they need a sample. So it involves giving a saliva sample or a blood sample. So there's options, because I know some people don't like needles. There's also, you can do a cheek swab. And then it gets shipped to the lab for the sequencing and looking through the genetic code. But genetic counseling is important, talking to someone about the benefits, the limitations, the risk of testing, so that you're sure it's something that you want to do, that the timing is right. And then the interpretation, understanding the results is so important. So there's a process of talking to a provider both before and after genetic testing, and continuously as you want to learn more about these genetic variants, especially if you test positive.
How long does it take to get the results?
Yes, so typically, once someone provides a sample and it gets to the lab, the results take about 2 to 3 weeks, sometimes quicker, but on average, it's about 2 to 3 weeks to get those results. And often women who are newly diagnosed with breast cancer are getting tested, especially if they're young, or if they have bilateral breast cancer, or if they have triple negative breast cancer, which is more common in Black women. It's an aggressive cancer. They'll get the test. They may want to rush it and have it come back quicker, because women can make treatment decisions like surgical treatment. Should I have a lumpectomy versus a mastectomy versus a bilateral mastectomy? So it's really becoming like integrated into the care of patients with breast cancer.
We keep hearing about the BRCA genes 1 and 2. Is that the only mutation you're looking for in genetic testing?
Right, so that comes up a lot. People hear about BRCA1 and 2 because they were, the first breast cancer genes that were discovered. If someone has a variant in a breast cancer gene, 50% chance it'll be in BRCA1 and 2. But there are other genes, like the CDH1 gene. Where I work, I see a lot of women and men who have CDH1 gene variants. That increases the risk for breast and gastric cancer. So it's important to report your full family history of cancer, not just breast cancer, because it can lead and make us think of other genes besides just BRCA1 and 2. So there's almost 20 genes that are associated with breast cancer. So if a woman had genetic testing in the past, or a man had genetic testing in the past and it was only BRCA1 and 2, and it was negative or uninformative, they should talk to their provider, advocate for themselves to get what we call gene panel testing, where you can test for several genes at the same time, and not just focus on BRCA1 and 2, because we know that's limited now.
You talked about the family history. That's a difficult conversation to have, because in a lot of cultures, we don't talk about cancer. It's the big C.
It's the big C.
How do you break through?
Yes.
How do you get the information from your family members? I know at one point they were talking about at reunions and holidays. Well, who wants to be the Debbie Downer and say who died of cancer at Thanksgiving dinner? But how do you get the conversation started?
Right. Well, getting the conversation started is through programs like this. If you see this program, make sure to let your loved ones know that, you heard and found out information about breast cancer. I think it's just important to integrate it into our everyday conversation, because cancer is a very common disease. 13% of women will get breast cancer in their lifetime. And so it's something that we need to destigmatize and become more open in discussing it, because we can save someone's life by discussing breast cancer and our family history, and informing the way you all are informing Jasmine about her risk. She needs to know that so that she can start taking care of herself, which what she's doing. She's already getting her screening, because that's important, because the youngest person in the family was 34 when your mom was diagnosed. So other close relatives should start 10 years earlier than that. So that's great that you started already, Jasmine. And also, if there is a gene mutation or variant in the family, that's the age we recommend women start screening with mammograms, and breast MRIs is at age 25, much earlier than most women start at 40.
Did you want to have that conversation? Did you want to have in the back of your mind that I might carry this gene mutation? Were there fears in knowing the facts?
I think because we've had these conversations throughout the years since I've been born, and we have this foundation that speaks to families and to the general public about the different fears too. I'm just like, we need to know. So fear set aside, we need to figure this out. So if I feel something, I have to speak up and say something. We'll deal with the emotions after that. But right now, we need to actually get the facts and see what the next steps are.
All right, I think Jasmine summed it up best. Get the facts, see what the next steps are. Ladies, Grace Ann, Miriam, Wendy, Jasmine, thank you so much for being here with us.
Thank you.
Thank you.
Our conversation continues, but first, Kimberly Higginbotham understands better than most that breast cancer doesn't play favorites with the young. Kimberly was diagnosed with breast cancer in her early 20s. Here's her story.
The biggest misconception about young women and breast cancer is they think they won't get it. I felt the lump, but didn't think that it was anything because no one thinks about cancer in a 23-year-old, especially breast cancer. I was dating my husband then, and I hadn't told him, and he hugged me and felt it. So that just shows you how big that it was. I came here to see Dr. LaSalle Fall Jr., a renowned surgeon at Howard. He said, well, whatever it is, we need to remove it. He sat my mother and I down and said, I'm sorry, but the tissue came back positive with malignant cells. So I knew the word malignant meant cancer. I knew the tissue had come from my breast, but I just couldn't put two and two together. I was just like, he can't be telling me at 23 I have breast cancer. So I just point blank asked him, are you saying I have breast cancer? He said yes. I started crying because I just knew that I was not ready for whatever was happening next. My mother said, well, what do we have to do now? And he said, we have to have another surgery, chemotherapy, and radiation. If someone is diagnosed at a young age, one of the main things they may be thinking about is their fertility. I was told that it would make it harder for me to have children because the chemotherapy can decrease the number of eggs that I would produce. So there are options where some people freeze their eggs before they start their chemotherapy. So you have to discuss that with your doctor to see if there's enough time for you to do that. And there are also organizations that can help you pay for that as well. And also just body image wise, some of them may not be married, so they're concerned about how their breast is going to look even with having a small portion taken out, because then that means their breast size may be different. But you have a plastic surgeon that you'll meet with, and the plastic surgeon can go over your options. And we shouldn't let any of these things keep us from the treatment that is needed to help us treat the breast cancer. I always had a lingering fear. Will cancer come back? Will it come back? Any little thing that popped up, I want you to first tell me it's not cancer, and then you tell me what it is. But so working at the hospital, I'm always running to my doctors and nurses. Okay, what is this? Can you help me? Can I get this test? Can I get ultrasound? Can you just tell me that it's nothing first? And in 2015, it was something. In the other breast, I was diagnosed with breast cancer. So I was upset because I knew what I was gonna have to do. But this time it was different because I had children. I had to see what I was going to share with them. And I was pretty open with them and let them know, well, mommy went through this the first time and she lost all her hair and daddy shaved his hair off for her. And he's like, daddy was bald, you both were bald. So, we made it into like a little joking thing and told him, like, mommy may not be able to come to all your games. She may not feel that great, but dad's gonna tell her how everything went and your grandparents will be there. So I tried to let them know that I may be down for a little while, but I'll be back because, mommy did this before. If you find something in your body that's different, don't be afraid to go to a doctor, to talk to someone, because you may need encouragement to go to that doctor. Share it with someone. Go to the doctor. Don't be afraid to go, because the sooner you find out if it is something, the sooner you can start getting it treated or addressed. We don't want to let fear keep us away.
Breast cancer at any age is daunting, and for younger women, issues around sexuality, fertility, and pregnancy are often concerns after treatment. Lavelle Williams-Smith is a pharmacist and was diagnosed with breast cancer when she was 31 years old. She was also pregnant at the time. What other challenges do younger women face? Are the guidelines for treatment and screenings of younger women different? Dr. Jacqueline Dunmore Griffith will provide us some answers. She is an assistant professor in the Department of Radiation Oncology at Howard University College of Medicine, and she's also the director of breast cancer in that department. And we thank you both for being here with us. Lavelle, tell me a little bit about yourself. Did you have any family history of breast cancer?
So no, I didn't have any family history of breast cancer. I was actually diagnosed 2 years ago. I was 31 years old. My husband and I had been trying to have a baby for a year and a half. So in January 2021, we were overjoyed. We were pregnant with a little girl. As a new mom, you try to stay in tune with your body. So it was, as I was in the shower, I realized I had a lump in my breast. I brought it to my mom and my husband's attention, and they were like, you need to go get this checked out. But maybe about 2 weeks later, I didn't feel the lump anymore, so I canceled the appointment. 3 weeks after that, the lump came back, and it was more pronounced this time. So I went to the OBGYN, and that's when they started, kind of routine breast exam to see what it was. And from that point, that's when the journey started. I had a ultrasound done, then a biopsy. I actually had a second lump in my underarm as well that I found. And I was diagnosed with stage 2B invasive ductal carcinoma. Yes, ma'am.
It's a mouthful.
It is.
How far along in the pregnancy were you at this point?
Yes, ma'am. So I was about 5 months pregnant. So at that point, because of the lymph node involvement, they did decide to do chemotherapy while I was pregnant. But the baby's organs were developed, so they assured me that, this would be the right time to start it. So I did do the chemotherapy, I delivered her early. She was healthy, but I did continue with chemotherapy, my Herceptin therapy, and then I also decided to do a double mastectomy with reconstruction as well.
Lavelle, the joy of having this baby, bringing this life into the world, while you're now fighting for your own life. Take us to those moments away from your husband, away from your family, maybe in the shower. What was going through your mind? How were you dealing with this diagnosis while you're trying to bring a healthy baby into the world?
Yeah, so when I was first diagnosed, my first reaction, once it really sunk in that I had breast cancer, was my baby going to be okay? And it was with rallying of the troops of sorts with Howard, with all of my care. They made sure that making sure the baby was healthy was going to be a priority. So I did have some moments where, I was in the shower and just kind of broke down and was like, why me? Like, what was the reason behind it? And I think it's for education, taking this experience and sharing it with others. I think it was the reason behind it.
Why did you want to share it with others?
Yes, ma'am. So because of my age and the lack of, family history with breast cancer, I had a lot of female friends who weren't doing self-breast exams, who didn't have family histories as well. But I wanted to share that information and let them know that early detection is key.
Early detection will always be the key. It determines the treatment philosophies that you follow. 1 in 3,000 women diagnosed with breast cancer are also pregnant at the same time. The treatment that Lavelle received, is that normal, chemo and putting off surgery? What's the protocol?
When you're diagnosed with breast cancer while you're pregnant, it depends on at what stage you are when you're diagnosed, where you are in your pregnancy, I guess I should say. So surgery can be done at any point in pregnancy, whether you're in your first trimester, second trimester, or third trimester, because typically the anesthesia is not going to cause harm to the baby. Chemotherapy is delayed into the second or third trimester because during the first trimester, the baby is still forming its organs and parts. And yes, chemotherapy can cross into the placenta and cause damage to the baby. So if we can delay giving chemotherapy into at least the second or third trimester, we will do that. But it depends on the stage of cancer as well. So in Lavelle's circumstance, she said she was a stage 2. When she was diagnosed, the good thing is she was already in the second trimester of her pregnancy. She was at 5 months. Because she had the lymph node involvement and her tumor was also hormone negative, but Herceptin, which is the third receptor that we look at, estrogen, progesterone, and Herceptin, it was recommended that she proceed with chemotherapy to try to shrink the tumor and give her better survival and overall care of her tumor without harming the baby. So it was recommended that she have chemotherapy, get as far into the pregnancy as she possibly could, and then deliver the baby safely. So for patients who are diagnosed with an early stage cancer, maybe early stage 1 or early stage 2 during their pregnancy, they could possibly go straight to surgery. But because of her lymph node involvement, and because the tumor was ER/PR negative, which we know can be a more aggressive tumor, it was recommended that she have chemotherapy.
And we do know that younger women tend to have more aggressive cancer, so it does determine the treatment and protocol that you follow going forward.
Yes, it does. It really does. So specifically for a pregnant person, they can have surgery at any time during the pregnancy if there's early stage cancer. If the cancer seems to be more aggressive or more advanced stage, then we would try to do the chemotherapy and delay surgery to after the baby is delivered. And there's absolutely no reason to give radiation therapy during pregnancy. So we try not to do the radiation therapy at all because radiation therapy can be very harmful to the baby.
Let me ask you this, Lavelle, what was going through your mind? But now that you've gone through this procedure, how are you now? What are your fears now? What are your concerns going forward?
Yeah, so of course, my baby's always at the center. So one of my concerns was, her increased risk of getting breast cancer when she's older. So I want to really drill it in her, my mom as well, just all the women in my family to make sure they're doing those breast exams. So I think that would be the main thing. But overall, I'm doing good, just trying to take it one day at a time.
All moms and dads are trying to do the same thing. Are you interested in any kind of genetic counseling or genetic testing?
Yeah, so fortunately, when Dr. Wilson was one of my providers, she suggested that I do the genetic counseling with Howard University. So I was able to complete that as well. So I did find out I did not have the BRCA1, BRCA2 gene that's associated with majority of breast cancers. So that was a good experience.
Took a little bit of pressure off of you.
It did.
Let me ask you this, doctor. While pregnancy is obviously a major challenge during any kind of breast cancer diagnosis, younger women who are diagnosed with breast cancer, what are unique challenges that they face that others who are a little more mature might not be concerned with?
Okay, so we know that breast cancer diagnosed in younger women can be more aggressive, so it can grow more rapidly. It has a tendency to be a higher grade, and it also has a tendency to be triple negative, all of which are poor prognosticators, if you want to look at it like that. So for a younger woman, screening mammograms and self-breast exam, and I think young women, no one thinks I'm going to have cancer, right? I'm young, okay? The biggest risk factor for breast cancer is having breasts and being female. Unfortunately, we are seeing it in younger and younger women. So right now, the screening guidelines allow women who are at low risk to start their screening.
Emphasizing low risk.
Low risk, meaning you don't have a family history of breast cancer, you don't have benign breast disease, so you're not at an increased risk of developing a breast cancer. So women who are at low risk can start screening mammograms at the age of 40. If you fall into a higher risk category, meaning you might have been exposed to radiation when you were a child, chest radiation, which can be a risk factor for developing breast cancer, that you have a family history of breast cancer or atypical cells within your breast, that puts you in a higher risk category, so you can start screening mammograms at a younger age. And that would need to be discussed with your physician to determine what age is best for you to actually start your mammograms. So for young women, as Lavelle was saying, it's very important to get the mammograms and to do self-breast exams. If you feel that there's something going on in your breast, if you detect a bump or a lump or you notice any changes in your skin, please bring it to a physician's attention as soon as possible. Don't delay. And one of the other issues with young women is because even physicians, we're not perfect, and physicians also don't tend to think of cancer as being a young person's disease. So oftentimes we hear about patients who go to a physician, there's something going on, and the physician doesn't guide the patient the way they should be guided, and they may ignore the signs and symptoms as well. So be your own advocate. If you really think there's something going on with your breast, please bring it to a medical provider's attention. And if you're not happy with the response you get necessarily there, seek a second opinion.
It's your body. You have a right to challenge what you know is going on that's not right.
That's true. Yes.
Now, again, some of the other issues, we started out by talking about sexuality, fertility, and whatever. What are complications for younger women having gone through treatment? Are they able to have other children?
Yeah. So fertility is an issue, especially in women who are still of childbearing age. So when you're diagnosed with breast cancer, before you get started with the treatment, you can meet with a fertility doctor, and sometimes we will do egg preservation in these patients, especially if they have to get chemotherapy. So before they start the chemotherapy, they can have their eggs taken and frozen, and then at some point later, after they're beyond the treatment and they still desire to have children, they can have the eggs implanted into their uterus and they can still have children. You don't necessarily have to do that, but that is an option. So we always try to work as a team, and we would have not only the surgeon, the GYN, but a fertility doctor involved too to discuss what different options are available to you. All chemotherapy won't cause you to lose your fertility. So during chemotherapy, there are different medications that can be used to try to help preserve egg function. And in younger patients, what we have found that you can have chemotherapy and it doesn't necessarily put you into a permanent menopause. Sometimes after the chemotherapy is over, the younger you are, the more likely you will have a period again. Your menstrual cycle will return, and then you can still bear children. Also, there's hormonal therapy. We don't recommend getting pregnant while you're on hormonal therapy. So those tumors that are hormone positive, typically a patient may end up taking a hormone pill for at least 5 years after they finish their treatment. And this is to prevent the breast cancer from coming back or to decrease the likelihood that it will. For people who are of childbearing age and they're interested in getting pregnant, you can discuss with your medical oncologist coming off of the hormone therapy and having a child while you're off of the therapy and then going back on the therapy to complete the 5 years of treatment. So there are options out there. So breast cancer does not necessarily mean that you will never be able to have children.
Lavelle, have you had these conversations with yourself, with your doctor?
Yes, I have. And it's actually a really good point that Dr. Dunmore Griffiths brings up. You know, there is life after breast cancer. Family planning is a big part of, you know, what's important to my husband and I. So I was very happy to, you know, hear that we would be able to start again to try to conceive, you know, once everything was over. But the premenopausal state, it's no joke. I had to apologize to many women in my family for laughing at them when they would have hot flashes because I now understand.
You have your permanent fan somewhere close by. How are you, though?
I'm doing very well. I actually recently started going to a support group at Howard University Hospital, and it's actually been a godsend, to be quite honest. I didn't know I needed that type of support. I've always had the support of my family and the support of my, you know, medical staff and team and things like that, but having that support from other survivors and other thrivers and women who are just going through their journey, it just means more than I think they really understand.
And your advice to other young women going through what you've gone through would be to seek out that kind of support?
Yes, ma'am. Definitely seek out that support. Do the exams, be your patient, you know, be your own advocate. If you really think something is going on or if you want to have something checked out, don't stop at the first no. You know, get that second opinion.
Now, you told us a little bit about the baby girl. Bring us up to date. How old is she? What is her name? And how is her health?
Yes, so her name is Elle Marie. She actually just turned 2 in August. She's amazing. When she was born, we did have her early, so she was premature. But once she got out of the hospital, it was only up. So she's super smart, very kind, and I love her so much.
So says her proud mommy.
That's right.
Unbiased. Lavelle,
Totally.
thank you so much for being with us, and congratulations on the baby and your health. Dr. Dunmore Griffith, thank you for the good advice. If a friend or family member has been diagnosed with breast cancer, you may wonder what you can do to help. Mark Hyacin is president and founder of Men Supporting Women with Cancer. Mark started the organization after his mother, Gloria, was diagnosed in 1992.
There are many, many concerns, obviously, when you're dealing with breast cancer, again, or any life-threatening disease. Every guy feels hopeless, helpless, and fearful that the person they love is going to die. I know from my experience, when my mom was diagnosed, my dad, my brother, and myself, we all wanted to switch places with her. The only thing that matters, it's similar to real estate. Instead of location, 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 she knows you love her, you love her, you love her, and you're going to be there, you're going to be there, you're going to be there. You may have kids, you may be empty nesters. So there's a lot of factors that go into it, but nothing more important than her knowing you're going to be there for her. My road to advocacy began in 1992 when I heard the 5 most horrific words uttered to me at that point: your mom has breast cancer. I was 29 years old and immediately felt like a little boy who thought, oh my God, my mommy was going to die. The organization Men Supporting Women with Cancer grew out of 2 succeeding nonprofit organizations. The first one was called the Gloria Hyacinth Breast Cancer Foundation, named after my mom. And the second one was called Men Against Breast Cancer. And from there, we morphed into Men Supporting Women with Cancer. And primary service that we offer is called Partners in Survival. I have a book that I wrote called A Guy's Blueprint to Caregiving. And what this book is, it's a blueprint. It's modeled after the Don't Sweat the Small Stuff series. And what the most proud of is this book is not me talking, it's all the families I've met across this country. When we first started developing our workshop, we did some focus groups at Johns Hopkins. We were with 8 married couples. People think men aren't good caregivers. It's quite the opposite. When given the opportunity, men are great caregivers. So what happens is each man was asked to grade himself as a caregiver. And conversely, his wife was then asked to grade him. Each man gave him a lower grade than his wife gave him. So you kind of extrapolate that into real life. The guys don't realize that the woman they love doesn't want us to fix it. They just want us to be there. It's such a hard concept to know that I can just pull up a chair next to you and put my arm around you, and that's all you want at that particular time. If somebody is there as a caregiver, then she can focus on her treatment and the outcome's going to be better because she knows somebody's going to be there for her by her side and she can count on that person. And sometimes it's crying with them. And sometimes, believe it or not, it's arguing. Because if you have an argument, a respectful argument, she may say, oh, hey, I must be doing okay because we're having a little argument. So this is okay. I'm good with that. I always like to end when I'm giving a speech or doing a workshop with a quote by Martin Luther King that I think applies to this above all else. Everybody can be great because everybody can serve. It only takes a heart full of grace and a soul generated by love. So what that means is be there for someone you love and you make a difference for them, you make a difference for a lot of other people.
The treatments have stopped. Your hair has grown back. The radiation burns are healed and your energy levels have returned to normal. You are now considered a long-term survivor. What will your life look like going forward? Thelma Jones understands this process from personal experience. She's an award-winning community activist, breast cancer survivor, and advocate, and she is the board chair and founder of the Thelma D. Jones Breast Cancer Fund. Dr. Sarah Horton is the Executive Director of Access and Diversity for Quantum Leap Healthcare, a nonprofit focusing on breast cancer clinical trials. Dr. Horton works to improve minority representation in cancer clinical trials. She is also a medical oncologist for the Howard University Cancer Center Transdisciplinary Breast Cancer Clinic. Thank you both for being here with us. Thelma, I'm going to start with you. You look fantastic, the picture of survivorship, but you call yourself a thriver and a warrior. What's the difference?
Thank you. The difference between a thriver and a warrior is a thriver is someone you sort of think about when they're dealing with metastatic breast cancer, as opposed to a survivor that's gone into remission. Mm-hmm. But a thriver, the cancer is still active as it is in someone who's metastatic. And so you keep pushing forward each day, given the circumstances that you're dealt with. When you think about a warrior, I always think about a person who's fighting when you're in a battle to survive. You know, there's that competition. You always want to keep pushing even harder. You want to use all the courage, the strength, the valor, the honor, everything to really win the fight against cancer.
And you're in it to win it for sure. You have been, as I said, a thriver and a survivor, but you've always been a community activist, a community dynamo. How did cancer change you?
Well, cancer changed me in the sense that it helped me to understand that if we really want to educate the masses, in particular those who are in our marginalized community, that it is important to be engaged in the community and to have a relationship, create some trust so that you can help to raise greater awareness and educate people about cancer. And in my case, particularly about breast cancer, because the statistics about African American or Black women is just dismal. And I live in a community in Southwest DC where I have a wonderful relationship with the community, in part because I've lived there and I've worked closely with the community to build trust.
You have your hand in almost every aspect of community involvement you could find in that area of Southwest.
And I'm still working for trying to get those patches that are not there, because the community is ever evolving. You know, that's the home of where urban renewal was. And there are elements of the lack of trust that's still existing. And with the Southwest community changing drastically, it's still important to be reminded that it is a community where we have more people. There's a greater concentration of public housing in Southwest than in any other community in the District of Columbia. So when you have a concentration of public housing, there are a lot of challenges. And it's so important that I continue to maintain a good relationship, because breast cancer is one of the challenges in my community. And it's just important to help educate, raise awareness about breast cancer.
You're a perfect role model, because we're talking about long-term survivorship, but when did you stop looking over your shoulder, being worried about cancer, breast cancer coming back after you?
Now, that's a really good question, because when I think more about it, I haven't really stopped looking over my shoulder, and it's in part because new language is coming out about breast cancer. And so when I was first diagnosed as a late stage 3B HER2 positive, which is an aggressive form of breast cancer, and it was rare according to my doctor, that in this country, when 95% of the women are diagnosed with breast cancer, doctors know the source or the origin. However, I was at 5% that we did not know that. And at the time, I was never told that a late stage 3B was considered metastatic. And now when I'm reading a lot of material, and I remember the first time I read that, I was stunned, because I know a bit about metastatic breast cancer, and that was just very alarming. It's like, am I now metastatic? So this is why it's important to keep reading and keep sharing your story, so that we can deal and be aware of the changes that are occurring that particularly can impact our bodies.
I want you to share one thing before we get to Dr. Horton talking about the importance of clinical trials. You are an advocate for early detection and prevention, but people may be surprised to learn that when you first noticed symptoms in your own body, you ignored them.
I did.
Why?
I really did. And that's a good question, and I'm happy to share that, because I was very busy at the time, which is...
Too busy to take care of yourself?
Exactly. I had just retired from the World Bank Group after more than 33 years, and it's like I could finally exhale. And part of my retirement was to go to Santa Ana, Costa Rica to study Spanish. And
of course.
And when just a day or so from when I was about to depart, I felt this lump beneath my arm, and I was like, oh, I'm gonna have to check that out when I get back. And I knew about feeling and identifying a lump in your breast, but I never knew that one of the signs was a lump beneath your arm, okay? And so, of course, I went to Santana to study Spanish for about a month, and I would feel the lump, and I'd always say, when you get back, you should check it out. But when I returned 5 days later, 5 or 10 days later, I was off on another trip to Guyana, and I would feel the lump then, and I'd tell myself, oh, this thing's getting a little bigger, feeling different. You need to check it out. I returned, and from December to March, I still did 3 other trips, and each time I kept telling myself I should do something about it. But I'm at a family reunion conference in Philadelphia. I'm showering, and the lump was very large and hard. And
you couldn't ignore it.
Thelma, you need to get this checked out. And
well, thank God you got it checked out and that you're here with us. Dr. Horton, hearing women who still kind of put things off, either they don't want to know it or they're too busy, is that something you've heard before?
Unfortunately, yes. And I understand, we're busy and for a lot of different reasons, be it family or work. And I know when I was treating patients, there were many times when we would get a patient who was referred and we would go through all these discussion about how serious this is, this diagnosis of cancer. But sometimes you could see in their face and they're thinking and they're asking about, I have to get home, I have a job, maybe no one's there with them listening to this. And, more often than not, before we had patient navigators, we would lose patients that way. And by that I mean that the patient may leave and never come back for a follow-up visit. And then in those instances, ultimately, they'd probably show up a little later. Of course, the disease had gotten worse. Maybe we had lost an opportunity to do some curative work, some treatments that would have taken this cancer away. So that became a focus when we were especially at Howard, because a lot of the women that we treat are women who are very busy. Yes. A lot of times they're women who may not have resources to take time off of work, have someone take care of their children. And so, there was just the necessity to put together this team, which is amazing at Howard, with a patient navigator, with groups like Thelma's groups and community engagement and patient advocacy groups that kind of swoop in and the Edith Williams group who come in and help support the patients to stay not only with the diagnosis, but throughout their treatment, because not only is it important for early detection, but it's important to follow through with the treatment so that you can have the type of outcome that you'd like.
Before we run out of time, I want to get to the importance of clinical trials. And part of Thelma's community engagement is getting people to understand the importance of clinical trials. Dr. Horton, why do we need representation of all kinds, especially in the Black community, in a clinical trial? What difference will it really make?
Well, I think I hope we know since COVID that the only way that we're going to find out some answers to some of our scientific questions, and by that I mean why some drugs work in bodies and why some don't, is if people are on clinical trials, and it's a volunteer effort. So no one forces anyone to be on a clinical trial in the United States, but it's a way for us to find out information so that we can move science forward, identify drugs that work better than what we have now, and that are safe and effective and don't cause a lot of side effects. That's kind of our goal. And the only way that we can identify these therapies is through a research test. And that's what we say when we say clinical trial. It's a research study where we are using patients to look at the best that we have and compare it to something that we think is even better. And so I know that a lot of times patients are very suspicious sometimes.
Right. They don't think they're getting the drugs, or they don't want to be guinea pigs, even if they want to help. So how do you get around? What's your pitch to get that person, convince them with the help of a community engager like Thelma to come in and be a part of a clinical trial?
One of the things that we're doing is we are trying to make the language that we use when we talk about clinical trials in a language that people understand, so that when we start talking about this wonderful opportunity, the person who's hearing it, the patient, understands the importance of it. They understand that they can leave the study anytime they want. They understand why it's going to benefit them, that this is a drug that could be better for their disease than what we have right now, and they're getting it before anyone else, and that you're being watched so closely, that the FDA is monitoring the study. So there are a lot of benefits on being on a clinical trial that I think that people don't necessarily understand. I think there's kind of that concept that it's an experiment, that, you know, someone's in a room by themselves and you're just kind of given this.
Right, they've heard the horror stories from the past.
Exactly.
Thelma, how do you make your pitch? How do you get them to understand that this is important and that they could be making game-changing treatments by being a participant in a clinical trial?
I think what I would like to do or think would be helpful is to come up with some jingles, because jingles, especially the younger generation, sort of can identify with things like that. Something like, your participation and involvement today is tomorrow's reason for a cure or better health. And just really pair that with some popular artists and help get the message out, just as we get the message out about early detection.
Exactly. Dr. Horton, last words from you on this possibly being a game changer when it comes to treatment and prevention, the importance again of a clinical trial.
So I just want to reiterate that now that we're getting more participation in clinical trials, especially breast cancer studies, we are starting to identify changes on a genetic level that we can start to target between women who have breast cancer who are Black versus women of a different ethnicity. And we're not all alike, but what we're finding is that as a group, we might have a higher likelihood to have a certain change. For example, we found out last year that the most curable type of breast cancer, which is estrogen receptor positive breast cancer, all women were in this study were treated the same and based on a score, and then they were followed. And they found that for some reason, the group of Black women did not live as long in 5 years as the Hispanic population, the Caucasian population, and the Asian. So now there's new studies looking at specifically why, delving deeper, trying to look at the genetics that we know might impact early recurrences. And so I think it's a continuum. We've got some ways to go, but because these women participated in that study and we were able to identify there's a difference, so now we're taking the next step.
All right, so if you're in treatment now, talk to your oncologist about possible clinical trials you can take part in and help be part of the change and the hope in the future eradication of cancer.
Absolutely.
Dr. Horton, thank you for being with us. Thelma D. Jones, thank you very much. Community Dynamo and the picture of survivorship. Thank you again. I'd like to thank all of our guests and experts. We hope the information you've received and the stories you've heard have inspired you to take better care of your health. African American women have a 40% breast cancer mortality, the highest of any racial or ethnic group in the United States. That 40% represents our mothers, daughters, sisters, wives, friends, people somebody loved, maybe someone you loved. That number also represents the potential threat to your own life if you don't take breast health seriously. Take care of yourself. Love yourself. You're the only one in the world like you, and the world needs your unique gifts. Thanks for watching. Please check the screen for additional information and contacts. I'm Andrea Roane. Goodbye, and stay healthy.
This program was produced by WHUT and made possible by contributions from viewers like you. For more information on this program or any other program, please visit our website at WHUT.org. Thank you.